Okay, so this is going to be a video on an advanced perturbation and neuromuscular progression. So we know there are key elements that make for an effective postural control and neuromuscular intervention. And there's 6 here that are laid out that I think are some of the most prominent and some of the most effective, demonstrating better outcomes. The first is optimal prescription. We need to ensure that the intervention has the adequate frequency, volume, and intensity appropriate to make physiological changes within the central nervous system and the neuromuscular system. This also entails feasibility and sustainability of the actual means by which a person can take part in the intervention. So this means usually low-tech equipment that can be transferable from one clinical practice setting or one home setting or one gym setting to the next. Additionally, we know it needs to be individually challenging for the individual. We also know that it needs to be variable. Variable practice within motor learning enhances the motor learning task at hand, allows for better transferability to novel tasks as well, and both of these need to be respected when providing an intervention. So it also likely needs to be adaptable over time, that variation is occurring and that progressive challenging tasks are applied. Comprehensive types of postural control, so this is static as well as dynamic tasks. Additionally, there needs to be anticipatory as well as a reactive element to their neuromuscular interventions. There's this unique concept that's coming more readily to hand and more evidence is mounting called sensory reweighting. In short, the explanation or definition of a sensory reweighting is where the brain develops a new task or puts more emphasis on a particular afferent or sensory input to be able to accomplish a motor task. So the example here is really within the lower extremity. In a healthy individual, they're going to be utilizing a sensory motor strategy. In layman's terms, that means they're using the sensory information that's coming up from the limb subconsciously to be able to then react to that sensory input from a motor aspect to create the appropriate motor strategy that is otherwise necessary. And because this is occurring on the subconscious and really on a less cognitively demanding level than is the opposing, and we'll get into that, then it allows the individual to better attend to the environment at hand and to be able to have a more robust strategy to prevent subsequent injury. On the other hand, what we see in injured individuals is this sensory reweighting where they rely more not only on a visual motor dominance, but they also develop a higher cognitive load for a given motor task. The negating effects of this are that the individual's cognitive bandwidth and visual bandwidth are taken up attuning to their internal processing rather than on the external environment, delaying reaction time, mitigating their decision making, as well as their speed and their overall physical performance. And so we need to be sensitive when we're implementing different interventions and training strategies that, one, we're respecting the sensory reweighting and not reinforcing it by any means, but hopefully we're coming up with novel interventions and progressions that would counteract this visual motor or this additional cognitive load that an individual experiences following lower extremity injury. And as we go through the progression explained within this video, I'll describe how I think that this progression actually gets directly at that, or allows for interventions and strategies to counteract the sensory reweighting. And then we also need to ensure that the intervention at hand is adaptable to the individual and that it applies directly or as close as we can to the motor task, the activity, the sport that they're trying to get back to. Within this described progression, are 5 levels. So you have level 1, initiation, level 2, intensity and distance, level 3, rate of stability progression, level 4, sport-specific task progression, and level 5, rate and sport-specific task progression. In the second column, you have the different techniques applied, and then the distance and the cord resistance. And these terms and these variables will make sense as we go through the progression in detail. So the different techniques, again, it's going to be a step and hold for levels 1 and 2 with a progressive distance in from level 1 to 2. And you can see the italicized and bolded text in the table denoting the variable that is being progressed from one level to the next. So from levels 2 to 3, you have 3 repeated step and holds requiring a more rapid rate of stability, hence the title of level 3. Level 4 is a step and hold, yet you're now incorporating ball tossing, dribbling, individual adjusted relevant sport or task specific activities. The core tension and the distance relatively stay the same. And then level 5 is a combination of level 3 and level 4 where you're incorporating both a rate as well as a sport specific task progression. So in level 5, you can see that you reintroduce the 3 repeated step and holds that were seen in level 3, and that's then combined with the sport specific and or activity specific tasks that are incorporated. You can see the asterisk symbol denoted in the annotation below the table that states performing exercises on unstable surfaces or without visual or cognitive distraction is suspected to reinforce that visual motor sensory reweighting that we talked about that is disadvantageous and can lead to subsequent injury, particularly when the individual goes back to their open and uncontrolled environments. Thus, whenever possible, interventions in exercise should be performed with eyes closed and visual perturbation, that is to say, rapid blinking or stroboscopic glasses, or sport-specific skills and neurocognitive tasks should also be incorporated. And one of the more common examples of this is using augmented or even virtual reality headsets in combination with such interventions to allow for the disturbance between what is actual false sensory information, forcing the brain to then attune to the sensory motor input and that more native strategy. Additionally, you can see the cross here in regards to the cord tension. So each intervention and each level should be appropriate for the just manageable challenges or just achievement of the task at hand. And this is going to be patient specific, and this can even dynamically change over the progression as the individual accommodates to the new variables that are being added, as well as it enhances their performance with their neuromuscular stabilization. Traditionally, the cord resistance is applied with a sport cord or TheraBand, but any accommodating resistance will otherwise suffice. Again, this gets to the feasibility and the applicability of the intervention across different practice settings or training settings. And then I've included a couple of sources there that were influential in helping me design these different levels. Okay, so you have in the first column different training variations. In the second column, you have the emphasized plane of that different variation. And then you have the actual broken down delineated tasks or exercises at hand for each of the different variations. Now, is convention within rehabilitation and training that help an individual to own what is the sagittal plane, that means forward and backwards, and then the frontal plane, that is to side, before you get to rotational and or combined planes of motion. And so the variations follow that same methodology. And so you can gradually introduce the different variations over time to someone's training program if they're not otherwise ready for the combined and or rotational planes. And then also keeping in mind that typically this is going to be prescribed 2 to 3 times per week, as is the most effective dosage when it comes to neuromuscular progressions and stabilization, postural control training. And so what this allows for is a cycling of these different training variations from one bout to the next. So on a given training bout, the individual would only perform one variation. And then this allows the exposure of the different planes of motion across a training regimen without actually having a superfluous or an infeasible amount of different variability within their given training task. For instance, if we were going to try and train all planes within a given training bout multiple times a week in combination with other stimuli and training that the individual needs to do, it likely would not be feasible nor sustainable. And so that's the key when it comes to periodization and programming appropriately. And additionally, this allows for structure, yet also variability within that structure, which we know that variability component is important for motor learning and task transfer. Okay, so then we're going to go through what do these actually look like. So here's an example of the sagittal plane. So you have an anterior step and hold away from the cord with the back of the patient to the cord. Then you have an anterior step and hold toward the cord, facing the cord. And then you have a posterior step and hold toward the cord, back towards the cord, and the respective posterior step and hold away from the cord, facing the cord. And you'll see the different variations here. Now, there is some redundancy within the anterior and the posterior stepping. However, the variables at hand are going to be dependent upon one, where the patient or the athlete starts relative to the amount of tension, and two, where their emphasis actually is. Is their emphasis on the explosive movement forward and holding and controlling that, or is it more on the posterior aspect where they're really trying to drive back into like almost like a reverse or defensive maneuver? And then as the athlete becomes more attuned to this, they can incorporate the visual perturbations and or occlusion through eyes closed, eyes blinking, if you have access to a stroboscopic glasses, and or virtual and augmented reality headsets, which are becoming more accessible financially and for people's budgets. I think that that's also a great means by which you could potentially progress within the phase. Okay, looking at the frontal plane now. So a couple additional variations that we can add within the frontal plane movements. So you have lateral stepping away from the cord, right side facing the cord, such as shown here. Then you would have the athlete flip around and do the reciprocal motion where their back would be to you. You'll see that in a moment. And then you have the facing of the cord and the facing away of the cord and those different variables, and the lateral stepping that can occur there. And though this may seem similar, as long as they're starting in the middle with the cord providing a direct posterior or anterior tension respectively, then it's still going to provide them a novel perturbation. Again, the same in-phase progression can be applied. That is to say, you can use visual occlusion. You can, if the person's not ready for hopping, it can be simply a step, but this allows for the gradual augmentation and rapid moment-to-moment progression and regression of this exercise to accommodate to the athlete's capability and where they are within their rehab, and then also ensuring those just manageable challenges to ensure that you're accommodating to the patient's current status, yet still providing a stimulus that's going to force physiological adaptation. And in these last two progressions where the athlete or the person is facing away or toward the cord, you'll notice that by the time they actually stabilize, that it's going to be almost like a diagonal and even a little bit of a rotational vector that the band is having on the pelvis. Okay, now we're getting into those combined movements. So it's anterior step, but with a 90-degree step and hold. And the introduction of the rotational phase, going from 0 degrees of no rotation to 90 degrees of full rotation, can often be a big jump for folks. As you can see, even this individual is challenged slightly with really being able to fully get to the 90-degree plant and hold. The foot actually hits the ground closer to 45 to 60 degrees. And that can be a normal phase progression there within. And not actually shown in these videos, but eventually what would be expected is instead of jumping from one foot to the other, the athlete would be going through the same progression, yet jumping from the right foot, then landing on the right foot. And then the therapist at their discretion can also play around with which direction the rotation is actually had, whether the athlete, in this case, as he jumps back, he's opening his hips and rotating at 90 degrees. But you could do that same leg progression where the athlete actually has to rotate in towards the limb, and it would not be necessarily an opening movement, but rather even like a closing rotational vector. So again, a lot of variability, yet there's still structure built within that variability for the routine. Okay, so this gets to sagittal and the lateral. So the difference than what you saw a moment ago is that though the hop is a diagonal one, the orientation of the athlete remains facing forward. Now, certainly you could add even a further rotational element where the athlete hops and rotates and faces the cord, and that would provide more of a progression than what you're seeing here. But the 45-degree angle and diagonal movements, irrespective of the direction of the hop, the individual is keeping their torso and their pelvis oriented in the same plane. So they would do it with each limb, going to each cone, facing first forward and then facing backwards. The additional variable that could be manipulated here, so as you're noting, the individual can either do a cross diagonal or they can do a same directional diagonal. That is to say, if instead of landing with the right foot here, the athlete could jump off the right and land on the left. And there's the posterior crossover diagonal, where you're landing on the contralateral foot relative to the side of that cone. And then the final one is the lateral and the rotational. And just like the previous rotational, again, instead of like opening up the hips and landing on the left leg here, you could also do it with landing on the right. And that would provide an additional challenge and would likely be a progression for the athlete. So all the videos that you're seeing right now are all just level 1 in that progressive level 1 through 5, where then you would add in additional distance, you would add in repeated hops for the rate of stability. Eventually you could add in a sport-specific task. You could imagine if this individual was a basketball player, they would be dribbling whilst they're doing this. If they were a football player, perhaps they're catching a football pass from the therapist. If they're a soccer player, maybe they're cutting and then striking the ball or volleying it as soon as the foot hits the ground. And then that level 5, they're doing the repeated rate of stability in combination with whatever those tasks may otherwise be. And if it's not a sports activity that the individual is getting back to, maybe it's such as like performing arts or what have you, then you can add additional creativity as well. But really, that level 5, the level 4 and level 5 are really trying to get at that element of what is going to be important and individual specific for that patient or for that athlete. And then next we'll talk about like the actual dosage of this to be able to ensure that we're giving the minimal effective dose. What is the least amount of stimulus such as this that we can put into an athlete's program to make positive changes in their static and their dynamic postural control, also known in more layman's terms as balance. The final example here is showing a neurocognitive task using a Fitlite training system. And you can see that this is the first time that the individual has used this type of stimulus, and thus he's quite unstable. But the goal being trying to get to that light that lights up as quickly as he otherwise can, and the direction at which he's hopping is going to be novel. This gets at that reactive element of postural control that I was describing. Additional, what could be applied here is, you notice that sometimes the light is red, sometimes the light is blue, And that would, you could also instruct the individual to do a different motor task. Maybe it's landing on the left foot versus the right foot, based on the color of the light. Other progressions that can be included here are added resistance. So perhaps you're adding a resistance band around the knees to reinforce more of a avoidance of that dynamic knee valgus. Again, you could be incorporating sport-specific tasks. It could be the therapist yelling out which direction to hop, or a combination of cognitive tasks such as attuning to a different stimuli, or in combination to the lights. So it can be quite novel, variable, yet individual specific. However, there's still that structured underlying framework there within that the therapist is working in, and also there's going to be dosing. So it can be a little bit challenging to appropriately dose neuromuscular and postural control-based interventions. There's a lot more literature on like how to structure sets and repetitions for strength and power and muscular endurance. And so there's a decent amount of evidence that has shown that using systematic reviews and more pooling of the literature, that there's actually about 6 to 10 repetitions or 60 seconds per set if you wanted to do it timed. You didn't want to have the athlete actually counting the repetitions, then that's another option. A minimum of 2 sets, and then the frequency has been described as anywhere from 1 to 3 times per week, depending on the training status and the load-bearing capacity that the athlete can actually take, and also considering where they are in their training season or in their phase of rehabilitation, what is otherwise being emphasized at that time. And keeping in mind here with the symbols, though these are kind of the minimal effective dose, the volume of the program is individualized to each patient based on the treating therapist or trainer, and based upon the patient's tissue response, training experience, and cumulative load across the different phases of rehabilitation, or if they're a healthy athlete and return to more team-based training, then that would also suffice. Okay, so just quickly revisiting the key elements of postural control and neuromuscular interventions that we described. Optimal prescription and volume based off the literature. We need it to be challenging and variable. We have that. Comprehensive types of postural control. We have static as well as dynamic. We've incorporated anticipatory as well as reactive. We've accommodated to the sensory reweighting and trying to adjust that, adjust for that principle, so that we're not only avoiding the reinforcement of the visual motor strategy, which would come with just sticking someone on a BOSU or unstable surface, but rather we're allowing for novelty and creativity on behalf of the therapist with strategic strategies or suggestions that have actually shown to promote more of the sensory motor dominance in the reacquisition there within of the central nervous system, rather than the continued reliance on the higher cognitive load as well as the visual motor strategy that usually transpires. And again, you can make these very task and patient specific. So here are a couple of references that have influenced the creation of this progression. I hope that you find it helpful. Please leave your comments in the section below. Always looking to get better, always looking for constructive feedback. And I know that when we put our heads together, we're better together than we are apart. So thanks for listening.